All right, good afternoon, everyone. Welcome to today's webinar on the operating costs and financial performance of Rhode Island's hospitals. This webinar is being hosted by the Rhode Island Office of the Health Insurance Commissioner. My name is Cory King, and I'm the Chief of Staff at OHIC. In a moment, I'm going to introduce Health Insurance Commissioner Patrick Tigue to kick things off with some opening remarks. Before I do that, I would like to provide some guidance on how to participate in today's webinar. First, during the presentation by staff from the National Academy for State Health Policy, participants who have questions can enter those questions in the chat. Our team will monitor the chat and pause occasionally to ask questions on behalf of the audience members where appropriate. After the presentation concludes, we will open the floor to further questions and comments. You can participate either by typing your questions in the chat as before, or you can use your raise hand function. When doing so, we can recognize you and you will be given audio and visual capabilities if you want to go on camera, and you'll be allowed to participate at that time to ask further questions or to make comments or provide other reactions. Finally, today's webinar is being recorded and it will be posted afterward on the OHIC YouTube channel. With that said, it is my pleasure to introduce Health Insurance Commissioner Patrick Tigue for some opening remarks.
Thank you, Cory. Thank you so much, everyone who's attending the webinar today for joining us about this important issue. As Cory noted, I am Patrick Tigue, the Health Insurance Commissioner at the State of Rhode Island Office of the Health Insurance Commissioner. I wanted to provide some very, again, brief remarks here to just frame what our partners at NASHP are going to present today. And I really look forward to a really, I think, fruitful dialogue as we walk through this. And so again, as many of you may be familiar, but for the benefit of anyone who is not, when the General Assembly created our office, OHIC, in 2004, it charged the office with several statutory purposes or statutory directives. Among those were to view the healthcare system as a comprehensive entity, and as well to encourage policies and developments that improve the quality and efficiency of healthcare service delivery and outcomes. And so these parts of OHIC's statutory purpose really speak to the necessity of bringing a holistic perspective to healthcare policymaking in OHIC's work and more broadly. And so consistent with these parts of our statutory purpose, OHIC has authored or commissioned reports that relate to features of the healthcare delivery system, and in particular, the hospital system in Rhode Island, given how critical Rhode Island's hospitals are to a well-functioning, high-performing, accessible, affordable, high-quality, and equitable healthcare system. And so this report that we have partnered with NASHP on is in that tradition of the type of work the office has really done in this area since 2010, and certainly more recently did work earlier this year and in 2021 as well. And so with that, I won't take up more time. I'll just say thank you once again to NASHP for this remarkable national work that we're able to leverage here in Rhode Island. And actually, I do want to take a moment and specifically acknowledge the leadership and financial staffs of both the Hospital Association of Rhode Island, its member hospitals, and Lifespan. We had very positive dialogue and engagement from all of them in advance of this data being made accessible and available. And so I want to thank them for engaging with the office and having a dialogue in advance about this data. And so with this, I will turn it over to Maureen Hensley-Quinn, who I believe serves as Senior Program Manager at NASHP. Maureen?
Thank you so much, Commissioner, and thank you for having us on this webinar. We are so excited to talk with all of you about NASHP's hospital cost tool and the data specifically for Rhode Island. First, I'll give a little bit of context. NASHP, or the National Academy for State Health Policy, for those that may know us, we are a national nonprofit nonpartisan organization that truly does have an academy of state health policy officials. That academy represents national agencies and offices across Medicaid, departments of insurance, governor's offices, legislatures, and more. That academy helps drive our work, helps us make decisions about where we focus our energies. And in about 2018, 2019, different state officials from multiple different states began asking NASHP for some technical assistance on how to address increasing hospital and health system costs. The interest was really driven to maintain affordable coverage, to maintain high quality access to care from institutions that are essential for our healthcare delivery system. But there's a growing concern about what's happening with costs. And so NASHP began working with Arnold Ventures, who supports this work, and in our efforts began looking first at transparency. So as we started developing some transparency models to understand hospital financials, different states alerted us to how helpful that was, but how it wasn't getting at the overall questions and issues on cost. There was a real interest in understanding what was driving these costs for hospitals, what their expenses were, and how they relate to hospital charges. And so NASHP, with help from Marilyn Bartlett, who came to our office from Montana, where she helped the Montana State Employee Health Plan better understand costs in her state, began evolving the hospital cost calculator that she used, sort of back of the envelope calculations in Montana, to ultimately lead the state employee health plan to adopting reference-based pricing there. However, over time, we started playing around with those calculations that are driven from Medicare cost report data that hospitals submit annually to the federal government to better understand some key cost metrics. So looking at cost to charge ratios and other points that Marilyn will go through in a lot more detail. We started working with states like Rhode Island who wanted to better understand what was happening with hospital costs. And we ultimately were able to work with partners from Rice University and Mathematica to create an online hospital cost tool that has multiple dashboards to look at multiple different hospitals across years from 2011 to 2019. And you can get a national picture. However, in our work, we really highlight the individual data for states like Rhode Island. Different states are using this information. In some states, it's really just a transparency opportunity that they didn't have before. In others, they are trying to leverage the data to be able to help inform negotiations. So state employee health plans, some employer programs that have their own health plans and purchasers are looking at this information. There are some states that want to better understand hospital consolidation and the effect that that's having on different costs. This tool allows you to look pre and post merger to understand cost trend information. And then ultimately, what we really hope it will do is help encourage discussions, help encourage dialogue. It's the data that Marilyn will present. We recognize their numbers need more information that hospitals and hospital associations like those in Rhode Island we're willing to have conversations only helps broaden everyone's knowledge and helps inform policy making. And that is ultimately what NASHP is hoping this will do, is help drive evidence-based policy making. So I just want to highlight that along on this webinar is Marilyn Bartlett, who will walk through the hospital cost tool, but also Adney Rakutanen, who has helped us immensely throughout this whole process to really understand the data, who ask critical questions, and ultimately to help us pull together this slide deck. And I believe also posted on the Commission's website is an Excel file so that you can dive into the data yourself. But with that, I'm going to hand it over to Marilyn, and she can walk us through the slide deck.
Thank you, Maureen, and thank you also, Commissioner Tigue. I appreciate this. We're going to share some information that came from NASHP's hospital cost calculator. The calculator is actually on our website. It's downloadable and you can use it. And the purpose of it is to help inform hospital rate negotiations. And we've been using it to look at pre-post merger and potential legislative initiatives. The calculator uses Medicare cost reports. Each hospital that serves Medicare patients must submit a Medicare cost report and attest to its accuracy. It is the only public source of hospital costs. We're starting to see hospital prices publicly, but this goes to hospital costs as well as the revenue. It was developed by NASHP. We worked with Rice University to validate the data, to also create benchmarks and work with us to link it to the HCRIS database, which allows us to have data since 2011 for over 4,600 acute care and critical access hospitals. Our work has been done with the support of Arnold Ventures. Next slide, please. One of the things that's critical is the cost to charge ratio. The charges are produced by the hospital. They have not been public. The hospital has total control over that charge master. And then insurance companies typically price a loud amount as a discount off that charge master. So what we've got here is the showing of the systems in Rhode Island. The blue bar shows you the hospital operating costs, and the red line at the top is the 100% of charges. So we show you that Prime Healthcare, for instance, is coming around 18% of the charges are their costs. And included in the costs are the operating costs of salaries, benefits, contracted services, and other things to perform the services. Now, the lower the hospital's cost to charge ratio, the less that it reflects the costs. And it's interesting because we've delved into if a cost to charge ratio goes down, was that because the costs went down or the charges went up? And we have data on that too. And most often it's charges that went up. Next slide, please. Key to the whole hospital cost calculator is break-even analysis. And this is what I used when I negotiated with hospitals in Montana. Break-even is an accounting term. It is when the revenues equal the expenses and there's no profit. It's just what revenue is needed for that hospital to break even. We calculated several different ways of looking at break-even, and we landed on what would commercial need to pay to cover the hospital's operating costs, all the Medicare disallowed costs, ancillary services, and any non-operating expenses or non-operating income. So it's the fully loaded. The NASHP commercial break-even is expressed as a multiple of Medicare so that we can do some comparisons. And we're able to compare it with the RAM 3.0 commercial price. And it is isolated to inpatient, outpatient blended. The only physician costs that are included are physician general patient care. That's 24/7 emergency room or ICU care, because all the other physician costs for direct patient services are billed through separate mechanisms. So the RAND and the NASHP commercial break-even do not include those sources of revenue or those sources of costs for direct patient services. We're now working with RAND to update to 4.0 and 2020 data, so you'll be able to get that. Again, both are expressed as a multiple of Medicare. If you look at our example here, you'll see that the green bar is what the hospital cost calculator calculates as this hospital's break-even point. It would need to be paid slightly above 150% of Medicare for that hospital just to break even. The dot at the top shows that this particular hospital in the RAND study, the price was 334% of Medicare. Now, we're not advocating that the hospital be paid break even, because we know that the hospital needs to make a profit and needs to look at other expansion or other services. But we're just saying that is the base, that there is a spread there for particular price negotiations. Next slide. Now, there are factors that can impact this break even. One is the Medicare payment rate. We use the Medicare payment rate that is applicable to each individual hospital, and individual hospitals will have a different Medicare payment rate based upon their case mix, based upon their outliers, based upon geography, wage index. So it would be unique. Now, if that Medicare reimbursement rate is covering more than the Medicare patient costs, and there's a little bit of profit margin already in that, then you would expect the break even to be lower, because we are using that unique Medicare payment rate. Hospital other income. If the hospital has significant other income, such as federal relief payments, I see in a lot of the Rhode Island hospitals that you calculate your DSH payments as other income. Return on investments, that will make the break even lower because that income source is coming in. Reimbursement from other payers, we do take into account any shortfalls or overages on any government programs, charity care, uninsured, so that the break even will cover any of that difference. And then there are always reporting errors. The hospital Medicare cost reports are verified by hospital leadership, but there can be times that maybe an item was entered in a wrong cell. Working with our partners at Rice University, we were able to isolate outliers and we removed them from benchmarks, but they are identified as outliers. So let's get into the data. Next slide. This is a snapshot of Rhode Island hospitals break even versus price, following that little model that I showed you 2 slides back. The NASHP break even price is from 2019 Medicare cost report data. The price from RAND is the blended price for 2016 through 2018, blended. And again, this is inpatient, outpatient. So let's look at the first one, Landmark Medical Center. Under Prime, you can see that the break-even price is coming, or the break-even would be lower than 100%. It's probably coming in around, let's say, 85%. So what we're saying is that commercial could pay for their services at 85% of the Medicare rate, and it would cover all their patient costs, any shortfall on government programs. It would cover all Medicare disallowed costs, and it would bring in that hospital's other income, other expense. So it's fully loaded there. The price per RAND, if you'll look at the top there, is running probably about 130% of Medicare. So that spread, that difference there, is a good point to negotiate from, or to take a look at from the commercial payer's point. You can go across and you can look at the differences for all of these individual hospitals. Now, when we get to Women's and Infants Hospital, you can see that it does the reverse. It shows that the RAND price is lower than actually the break-even cost. This is an anomaly, mostly because of many of the services provided there are not priced accordingly within the Medicare database, in Medicare system, as there are not a lot of pediatric or maternity codes. And so you kind of have to, we'd have to dig into that a little bit deeper. Newport Hospital, the pricing appears to be fairly close break even with the price that Rand had. But this gives you just a general picture over these specific hospitals. Next slide. So let's take a look at this. And we shows you the number of hospitals in the parentheses. Here we're looking at the systems. Now we've moved to the system level. And this is the median within that system. And you can look straight across. You can see again, if we go to, let's go to South County Health. We can see that the break-even point is actually running around 160% of Medicare, and the RAND price for those inpatient outpatient services is probably around 225%. So it's the same logic we had in the other slide, but this particular slide is looking at the medians within those systems to give you a little bit better picture on that. We did dig down a little bit into South County Health because we were trying to look at what was going on there. They seem to have some large Medicaid losses, and it appears that the reimbursements have stayed fairly flat over and we'll show you this in a little bit, over that 10-year period, but the costs have substantially increased. Next slide. So now let's take a look at the national median. This is Rhode Island versus the national median for the commercial break even. And it's interesting because it's following pretty much the national median line. National in 2020, you can see the blue line here is the national, and it's coming in around 118% of Medicare. You look at Rhode Island, it's slightly higher at 122. In 2019, they were very close. And that year, I know national was 127% of Medicare. And this is interesting. We're finding this relatively the same in most states, that national is coming in around between 120, 130% usually. Next slide. So let's dig down. Let's take a look at each of these hospitals. Now, what we're going to show you here is payer mix, profit and loss by payer mix too. So if we look at Roger Williams, the donut chart will tell you the makeup, and this is the makeup of the patient care. It's not revenue. We do it by charge masters, so it involves pretty much the intensity and the makeup of that payer mix. They have the Medicaid. You'll see that there is a significant loss on Medicaid, and you can see that the yellow bar shows that they also have a chunk of the payer mix. Now we do what we call a payer mix adjusted profit. What happens here is that a hospital could have a 40% loss on Medicaid, but perhaps it's only 6% of the payer mix. That tells a different story than if it were a larger amount. So we do weight those to kind of look at what is the impact to this particular hospital. You can look at the box because we wanted to bring in these other metrics. The NASHP commercial break even is 99%. So basically, if commercial paid 100% of what the Medicare rate is, that hospital would break even. The RAND study shows that the price is running at 122%. Net profit, 1.9. I looked at this particular hospital and I thought, well, gee, we're looking at the operating profit in that middle box, but we're showing the break even, which includes other income, and the net profit margin shows that other income. And I saw that there was 4.3 million of other income received by this hospital in 2019. Next slide. Our Lady of Fatima, we take a look, same thing. You can see a little bit heavier on the commercial payer mix than the previous hospital. You can see the profit margin and you can see the loss on the Medicaid. Again, our commercial break even is 120%, pretty close to that national average. And the RAND price is 130%. This hospital also shows a good net profit margin. Again, moving from operating profit margin to net profit margin, this hospital showed 2.7 million in other income that raises that net income and would lower that commercial break even. Next slide. Newport Hospital. We can see a much higher mix of commercial, and we see a little bit lower mix of Medicaid. I've been looking at these Medicaid losses. This one is running slightly higher than a minus 30%, and their commercial is running closer to a 50%. Again, jumping up to that box, this is a good summary to show you the commercial break even of 174%, a little bit higher than the national is. The commercial break even per RAND, 169% net profit margin is showing a particular loss. I think since you all have these slides or access to them, we'll go through them and leave more time for questions at the end. So let's move to Rhode Island Hospital. This one's showing a little bit different picture. This one shows a little bit lower commercial makeup, but again, a pretty high profit margin on that, closer to 50%. Medicaid is showing a lower loss. It's a little bit over 5% loss with that population. If you look at the weighting, you'll see the impact of the payer mix on that profit margin. We multiply those two together to give you a relative impact. So you can see with Rhode Island Hospital, the significant impact commercial has to the other payers. I should be pointing out too that you should be looking at the profit or loss on Medicare, because that's going to impact that break-even point. This hospital does have profit margin on the Medicare and Medicare Advantage. The commercial break-even, it was right on the national average in 2019 at 127%. The RAND 3.0 price at 160%. Now this showed a loss for the net profit margin, which means that it had a loss on its other expense. Next slide. Miriam Hospital, a lower population mix on Medicaid, but pretty strong population mix on the green of Medicare and the blue of Medicare Advantage. I also should be pointing out to look at those other slices of charity care and uninsured. They've been running around 1 or 2%. That is of the population mix. Now we look at this and we see about a 20% profit margin on the commercial and a higher loss, I should say, on the Medicaid. But when we put out the relativity, you can see the impact of a little bit lower Medicaid population, even though it is a larger loss. The NASHP commercial break-even is 92%. The RAND price is 196% of Medicare, and the net profit margin was just about a break-even for this particular hospital. Next slide. South County Hospital, large commercial. Look at that. That's looking like about 50% and making a significant profit on that. The Medicaid loss here is 100%, but it has a smaller Medicaid population. Again, we dove into this a little bit deeper because we were trying to figure out those large Medicaid losses. And when we took a look at this hospital, we saw that over from 2011 through 2019, the revenues were fairly flat, but the expenses almost tripled. And that's the cost assigned to Medicare, the cost per adjusted discharge, and we do have that available. So that seemed to be a cost issue on this particular slide. So the NASHP commercial break even's 166%, RAND running at 222, and this hospital does show a net profit or net loss on the bottom line. Next slide. Kent County Memorial Hospital. Again, you can see a strong Medicare Advantage population mix and strong commercial. A little bit lower on Medicaid than we've seen in the other hospitals. Looking again at the profit on the commercial, probably closer to 70%. A loss of about 30% on Medicaid, but they are making profit on their Medicare and Medicare Advantage. So the break even comes in at 161%, the RAND price 186%, with a net profit margin close to 2. Next slide. Women and infants. Large Medicaid population, which probably is not surprising with the focus on women's and infants, a loss of around the 30%. I've been seeing this kind of consistently on these hospitals on the Medicaid losses running around that level. Commercial payers, a large population of commercial with the profit margin, again, probably that's a little lower than 50%. We then weighted by the population mix, so you can see there. The NASHP commercial break even is 147%. As I indicated previously, the RAND pricing is going to be heavily influenced in that there aren't specific Medicare codes to relate to some of those services provided. So that is an outlier at 82%. Net profit margin is minus 1.5. Landmark. Here we see, this is really interesting to me. Landmark shows a significant profit on Medicaid where the other particular hospitals didn't. So I took a look at this and I saw that there were significant profits significant supplemental payments. So I drilled down to the specific Medicare cost report. Now you'll see, or on Medicaid, excuse me, the Medicare cost report Schedule S10 addresses Medicaid. And you'll see that this particular hospital has a fairly lower commercial, but they have a close to 50% profit margin on Medicaid. And when I looked at their reports, they entered a significant amount, which the other hospitals did too, but this particular hospital had higher amounts for DISH and other supplemental payments from Medicaid. So it was showing significant profits because of those two line items and how they were categorized. So it might be interesting to drill into what those specifically are compared to the other particular hospitals. Because there is significant profit there, it's going to drop that NASHP commercial break even down to 83% compared to the RAND price, with a net profit margin of 4.2%. Next slide. Westerly Hospital. We've seen this kind of before with that payer mix. They have a large Medicare payer mix, large commercial, a little bit smaller Medicaid, again showing a loss about minus 45% on Medicaid. Again, you can jump up to the summary box and you can see break even at 131, RAND price 169, and close to break even for net profit margin. Next slide. So let's take a look at the medians for all of the Rhode Island hospital by payer specific. Now this, we take you back to 2011, and this is the median, the median payer specific mix. So if we look at the orange line, that's commercial. So what was the profit margin on commercial? It was coming in around 40%. Again, the median has dropped. We go to 2020, the COVID year, it dropped to 20%. The blue and the green lines will pretty much run parallel between Medicare Advantage and Medicare as far as the profit margin. And Medicare median has dropped to a little bit below -10%. Medicaid was running fairly level at -20%, taking a dip to come in around -35% in 2016, and it remained fairly flat till 2020, and it dropped to closer to the -38%. One thing we want to point out here, the Medicaid or Medicare cost reports do not include any of the COVID public health emergency funding. So any of the provider relief funding, FEMA funding, any of that funding that went to hospitals that was meant to cover lost revenues or additional expenses is reported as other income. So it's not going to show up in the operating profit margin here. Next slide, please. So let's take a look at the Rhode Island median payer-specific relative impact. So that is the slide where we take a look at the payer mix times the profit or loss for that particular payer. And we see that commercial relative impact has dropped down to just a little bit above 5%. Medicare, Medicare Advantage has remained pretty flat, dropping a little bit in 2020. But the relative impact of Medicaid has been fairly flat through 2015. We saw that the operating margin dropped to 2016, but combined with payer mix, it stayed fairly flat, but still coming in around -8%. So this is a good look at that combination of the payer mix and the operating profit loss. Again, the COVID-19 public emergency funds are not included in these charts.
Marilyn, let's pause here for a moment because we have a question in the chat. The first part of the question is asking for some additional detail in the Excel spreadsheet that's currently on the website. I'm going to skip over that portion of the question for the moment. I want to focus in on the latter part. The questioner asks, how do you derive commercial and Medicare Advantage profit margins? They say, I don't believe those payers are specified in the Medicare cost report. So do you want to explain briefly the methodology you use to derive what the profit margins are on commercial and Medicare Advantage and how you were able to allocate revenues and costs to those payer types?
Certainly. First of all, on Medicare Advantage, we use a formula that actually brings up the patient level and the charges related to Medicare Advantage based off of a schedule in the S worksheets assigned to Medicare Advantage. So we worked with the state of Colorado to come up with a formula that would estimate. So it's a pretty close to estimate of the charges based on the reporting of the Medicare Advantage inpatient bed stays. And we priced it for this purposes at the same as Medicare. We realize that some services are reimbursed higher. As a default, if it's not covered under the Medicare Advantage plan, then it goes to Medicare. Then as a default, we subtracted all of the charges for the Medicare, Medicare Advantage, Medicaid, CHIP, charity care, bad debt, and uninsured, other low-income programs that were all calculated, and the remaining amount of charges were assigned to commercial.
Thank you, Marilyn. And Dawn, if you want to follow up with me after the webinar on the first part of your question, it was around the specifics of what schedules and lines and columns the data are derived from. So we can take that back. So please follow up with me. My email is on our website. So want to go to the next slide, Marilyn?
Yes, please. So now we're looking at net patient revenue. Now we bring in adjusted discharge, and adjusted discharge is a standard calculation used by the industry where we use the inpatient count applied to outpatient charges to come up with a blended count of the inpatient outpatient discharges. So the correct term is adjusted patient discharges. We divide that into net patient revenue and we divide it into hospital operating costs. And the spread between these two is the hospital operating profit that you've seen in the previous slides. So we take a look at 2011 through 2020, and this is the median for the Rhode Island hospitals. So you're going to have some higher, some lower. So this is the median. The green line showing us the net patient revenue per adjusted discharge, and the yellow showing us the hospital operating costs. Again, we did not include the public health emergency relief funds in this. So this is prior to any relief funds received in 2020. And you can see that spread in the operating costs. And it was managed pretty evenly until we got to 2020. But again, this does not show those additional funds. Next slide. So we look at the difference there. We're bringing in the major systems and we're looking at the medians within those systems. And this is the operating profit per adjusted discharge. So let's take the green line. Care New England, 2 hospitals in that system. And you can see the pattern that it was around $3,000 operating profit per adjusted discharge, is coming on up a little higher and then dropping down in 2020. You see the blue line, which is lifespan. You see the operating profit kind of paralleled right there with lifespan. Then it dropped the operating profit down and then dropped in 2020. The last one is Prospect, kind of a different curve to it, but kind of parallel with lifespan from 2015 through 2019, and then dropping to a negative position of $1,000 per adjusted discharge. Again, there are no public health fund or public emergency funds included in these calculations, but this is the system's operating profit per patient, basically. Next slide. Let's take a look at the bottom line, and we're comparing this to national. The blue is going to show you the national running around 4% going up to 5% in 2020. This is the net profit margin. This is going to include the public emergency funds. It's going to include all items that we had mentioned before. It's interesting because in most states, we see a fairly flat trend, but in some states where there are fewer hospitals, then you're going to see this zigzag a little bit when you go to the median. And it's helpful to drill down and see what really did hit that median in 2016. A lot of times we'll see that it's a large fluctuation in the stock market if there are heavy holdings in investments. But if you look at the Rhode Island net profit margin median, you'll see that it comes up in 2020. Again, now, excuse me, this did not include, I apologize, it does not include the hospital public health emergency funds. So nationally, it was at 5% without those funds. The median in Rhode Island is probably at about 0.5% without those funds. Next slide.
Okay.
Thank you. That's a brief view.
Yes, I think you are at the end, Marilyn. So if folks have questions, comments, or reactions that they would like to make, we've got about 15 minutes left in our scheduled time. So if you should be able to use your raise hand function. If you can't find that or can't figure it out, just send me a chat or put something in the chat saying, my name is such and such, please recognize me. And I can do that here as well. So do we have any questions or comments or reactions?
And as folks are doing that, just to give the people a second, Cory, I'll just say, first of all, say thank you to Marilyn again for that really comprehensive review. Again, as she and Cory and Maureen noted, this is all entire, this presentation, as well as an Excel spreadsheet with the data that it's derived from, and a cover letter from our office contextualizing this information. This is all available on OHIC's website, as well as NASHP's website has the comprehensive national NASHP hospital cost tool that also includes all of Rhode Island's information, as well as all the national data that Maureen and Marilyn were talking about. And ultimately, I would say, as a way of just framing the discussion here, from OHIC's perspective, from my perspective, I really believe this information can be incredibly helpful to really stakeholders statewide, whether or not you're talking about those of us in the executive branch here at OHIC and my other colleagues here in the executive branch, members of our General Assembly and the legislative branch, our hospital here in the state, our payers, and as well as employers and consumers. So it really is our hope that this is ultimately data that, and level of transparency around this data that can really support ultimately ensuring that Rhode Island has a hospital system that really, in my mind, has really the following fundamental features. The first is that you see affordable and predictable healthcare cost growth from the hospital system. Second is that we see improved financial stability for our hospitals here in Rhode Island, which obviously during the pandemic have been challenged and continue to be in many respects. And then finally, that we're able to see the investments in technical innovation that's going to improve population health management and quality outcomes, and really ultimately have an accessible and equitable system here over the long term. So that's really our hope for this data. And I want to really thank everyone for attending today. And so now we'll open up to questions. Cory, I'll let you moderate those.
Yeah, so I saw a hand briefly go up and then come down. So if for some reason that's an error, okay, great. First, we have a question in the chat from Karen Malcolm. Then I'm going to go to Al Charbonneau, Aaron Robinson, and then Lynn Arditi in the chat. So we have 4 questions queued up. So Karen Malcolm is asking, I didn't see our 2 behavioral health hospitals, Butler and Bradley, included in the review. Did I miss that? Marilyn, do you want to address which hospitals are in and out of the Medicare cost reports?
Yes, thank you. That's a really good question. I appreciate you bringing that up. Our analysis, we zeroed in on 4,600 critical access and acute care hospitals. We did not include the psych hospitals, specialty care hospitals, cancer centers, as the funding sources and some of the data doesn't really kind of fit this same model. So those are excluded from this. We did run them through the tool. We have the data, but they didn't line up for comparative purposes. And I'm glad you bring that up because I should have gone over the bullet list here to let you know, to answer some of your questions. The NASHP site includes the actual hospital cost calculator and the full instructions. So you can see what row, what column, what worksheet, what cell, you can see what is included. And then we do have an online tool now, an online dashboard that you can access to get these same graphs and plus more.
Excellent, thank you for that. So next I'm going to recognize Al Charbonneau. So let's see if I can do this. Al, are you with us?
I'm here. Can you hear me?
Yes.
Okay, excellent. I guess my question is, first of all, I think Marilyn knows that I've spent a fair amount of time with the model and think it's really superb work. But my question is really for either Patrick or you, Cory, and that is, I think it was Patrick that mentioned good dialogue with the hospitals in the state here regarding the tool and the report, and I think that's great. But I'm wondering, are we going to hear formally from the hospitals? Perhaps it's the retired hospital CEO in me, but I would like to hear what CFOs think of these data, what the people who prepare the cost reports locally think of these data. And I think it might be valuable if Harry, the Hospital Association of Rhode Island, were to be asked to respond in writing to this report. Thank you.
So I can speak to our process just very briefly. We did meet with the hospitals. We shared this data with them in advance, the complete Excel spreadsheet, as well as an earlier draft of the slide deck. And we had, I think, very productive meetings with Lifespan and the hospitals that comprise the Hospital Association of Rhode Island as to whether, there's an expectation that they formally respond to it or not. I mean, that's not really up for us to say. I think we wanted to put this information in the public domain so that we could have a data-driven and informed discussion around healthcare costs and hospital costs in the state. That's really the only agenda we have, is just to enrich the discourse And I think that the hospitals and purchasers and regulators are all going to find data that is interesting and is useful to them in this report. I want to be very cognizant of time, so I'm going to recognize Aaron Robinson next. Thank you for your comment, Al. So I'm going to bring on Aaron. Aaron, let me know, can you hear us?
I can hear you. Can you hear me?
Yes, sir.
Okay, so Al's question was a good segue. And I guess what I would say that I find extraordinarily interesting in the data is that many of the hospitals in Rhode Island, you have in your data making a healthy margin on both Medicare and Medicare Advantage. And to Al's question, as it relates to what the hospital CFOs would say, I know what mine would say, which is, I want to see which hospitals breaking even or making a margin on Medicare, particularly in the state of Rhode Island, because in these years, you have years where the imputed rural floor issue was in effect. So Medicare was actually significantly underfunded for the state of Rhode Island, yet you have profit margins in the 10% range for many hospitals, both for traditional Medicare and MA. I don't know really any hospital, any of my colleagues that believe they're making any sort of margin. We know that combined underpayments for Medicare nationally were in the 100 billion range, up from 75 billion in 2019, going into 2020. So it's curious to me that you're showing your analysis, your methodology is showing margin in those areas. And then if you look at the data on Rhode Island revenue and costs, it would suggest that for 19 and 20, there should be margin, while when you see the net profit margin in the hospitals, it's significantly different story. So it's curious how those two data points reconcile from a veracity perspective. So, a lot of questions from my perspective. I can tell you, I think there would be a lot of questions from my colleagues across the hospital industry. I think the last graph that you showed on the lack of margin across the hospital industry in Rhode Island is probably the most accurate, maybe understated. But in any event, I think more questions than answers from a hospital perspective.
Thank you, Aaron. We have a few more questions. I don't know, Marilyn, was there anything you wanted to address in Aaron's comment, or would?
No, one thing I will say is that the Medicare profit margin was taken from the Medicare cost reports reported by the hospitals. We did have the opportunity to reconcile the hospital cost tools calculation of Medicare profit or loss with a large health system, and went through their hospitals, and they agreed with it. So it might just be some interpretation of the hospitals. We did just recently reconcile it with a very large hospital in another state, and they did reconcile. So it would be interesting to know what those differences would be. And then the big difference, of course, between your operating profit and loss and your net income is going to be those other income items, and whether or not you're bringing in your DSH payments. And I saw, it was interesting because I saw in some of the hospital reports an item called OOI, which is usually other operating income. And for some reason, the hospitals were bringing that in as other income when it really should probably be up in operating. So you can get into that level of detail if you want to, but any feedback, we'd sure appreciate it.
So what I hear you saying is that you validated the data with some hospitals. I'm curious how many hospitals nationally you see making a profit on Medicare and Medicare Advantage in your data.
Oh, I just ran it for one state, and Well, it depends on the mix. We can sure take a look at this, but it's pretty large. And if you look at the MedPAC reports, you'll see that I think their average is making minus 2%. But we do see a lot right kind of in that realm, but I'm not saying that's the exact in this state, but we can surely take I'd be glad to get back to you with that.
But your contention is the majority of hospitals are making margin on Medicare, which is exactly the opposite of what most hospitals would report that I'm aware of. Nationally.
Yes, I agree. Most hospitals will say that there is a loss there. And I'm going to not say what our data says totally, but I'll get back to Cory on that, on what the national spread was.
Yeah,
I just think it
let me just move us
questions the
along.
validity.
Yeah, so the data is actually on the NASHP website. I think you can download the complete data set, but I mean, I think we're definitely interested in having continuing dialogue on this. I want to move us forward. Lynn Arditi has been patiently waiting in the chat and now with her hand up. So Lynn, I'm going to recognize you and let you ask your question in person. So it'll just take a moment. Lynn, are you with us? You are showing as being on mute. So if you take yourself off mute, you should be able to.
Can you hear me now?
Yes, we sure can.
Okay, great. So I was interested to see that when you looked at the for-profit hospitals, for example, like Landmark, which is owned by Prime, that 130% of the Medicare for the RAND commercial price index, that 130%. And I'm wondering, do you typically see across the country the same types of differences between for-profit and nonprofit hospitals that you're seeing in Rhode Island?
That's a good question. I have not done a comparison of the RAND pricing on for-profit, not-for-profit. Our focus is unfortunately, or fortunately, has been on the hospital cost tool. What I standardly see on for-profit hospitals is a lower cost to charge ratio. I see the lower costs. I see in the trend on the for-profit hospitals, I don't see the upward trends that I typically see on not-for-profit when we're looking at net patient revenue and operating costs per adjusted discharge. I see the not-for-profits costs and net patient revenues going uphill with a spread. I see the for-profits a little bit flatter. But as far as comparing to RAND, that's a tough one because it depends on who participated in RAND and what that data set is. Now, I believe you had a lot of data run through. So I really wish I could give you a better answer, Lynn, on that comparison to RAND, but I don't have that answer.
Okay, well, just as a follow-up, in lay terms, what does that tell you when you see that difference in between the for-profit and the nonprofit?
What I see, and I can't, I see that so typically I think that the cost level, the cost per adjusted discharge on the for-profits is kind of kept a little bit lower. It appears that on the not-for-profits that the costs go up and then the revenue is raised correspondingly, and that perhaps, and I have read this in articles, I can't validate this, but on the for-profit systems, earnings are usually given back to the investors or put into other investments, where on the not-for-profits, those earnings usually go into buying other things for the hospitals, whatever. And so the constant raising of revenue to match constant raising costs are something I do see a little bit more.
Okay, so we have time for probably two more questions. Hub Brennan has presented a question in the chat. He says, great presentation. I agree with Hub. Great presentation, Marilyn. Being aware that the cost of care are the major drivers of costs, do we have any data on corporate service expense as it relates to hospital or system profit or loss? I'm not
Could
sure.
you define corporate service expense for me? Is that like home office costs or?
So Hub, if you're listening and you could clarify your question, please do so in the chat. I will note that what's interesting about the data that we have posted on our website is that there's cost allocated to patient care delivery, and then there's other operating costs, other operating expenses. And so it's really looking at those two quantities in total, which determines those net profit margins in comparison to revenues and then other income. So I think if you're interested in really digging into the data, you can look first at the OHIC website, where we have the data published for 10 years, as well as the NASHP website. I saw that Teresa Paiva-Weed had her hand up. I'm not sure if she's still with us. I would like to take a question or a comment from Teresa if you're interested in doing so.
And Cory, it does look like Hub clarified his question as executive expenses, how he was defining corporate service expense.
Oh, I see, executive expense. So that was the question from Hub was on the,
I think the question, Marilyn, is how, excuse me, if we're able to break out the influence of executive expense on hospital profit and loss from the data set.
we didn't, the hospital cost reports do not give detail on executive compensation, executive expense. We are doing some additional work though in looking at administrative in general and home office. The current data set doesn't show that, but we are doing a little bit more digging on that. That's a very good question and a good observation.
Okay, so I think we can obviously follow up on that question. I see that Teresa Paiva-Weed has her hand up, so I'm going to recognize her, and then that will be the final question or comment of the webinar. So Teresa, are you with us?
Just because I just wanted to mention, can you hear me okay?
Yes, we sure
Great.
can.
I just wanted to mention that the CFOs did receive a presentation earlier, and as you can imagine, they had a number of questions. And just because Al mentioned, we look forward to continuing to work with OHIC and others to address some of the issues that are raised here, but two that I think are very important things I should mention is that we've asked that there be more of a focus on regional costs because once again, we are so much part of Massachusetts and Connecticut versus national costs, and we've asked for some dialogue along those lines. I think I should also mention that Landmark is a not-for-profit hospital, just because there's been some discussion about Landmark, and they've been not-for-profit now for a couple of years. And the final thing is, I'd ask perhaps if the panelists could address some of the things that aren't considered here, such as medical research and things like that. We've done a lot of discussion about this commercially reasonable rate, but just that not everything is in the cost reports. But we look forward to continuing to work with OHIC on these issues. And Al Charbonneau.
I want to add one thing, research and all those costs are included in break even. So that we did pick up all Medicare disallowed costs because we felt that we'd give the whole picture.
I guess I should ask what is not included. We were told at our briefing that was not included, or maybe it was the graduate medical education that wasn't included.
All of that is included. Medicare disallows medical education, Medicare costs. So when we look at operating profit, those things aren't in there. But when we do break even, we include all Medicare disallowed costs. They are all covered.
So I think what I come away with from this presentation, this discussion, is that we now have this data set in the public domain that allows us to ask these questions and to have these discussions around hospital costs that we didn't previously have. And to the extent that there's an interest in conducting regional comparisons, the data is out there now. The data is on the NASHP website. And like I said earlier, I think that the hospitals and healthcare purchasers and regulators all can find interesting and valuable use cases from this data set. So thanks everyone for your rich engagement today. Marilyn, Adney, and Maureen, thanks so much for your excellent presentation and for being able to provide this really valuable access to your data for the state. We really appreciate that. Commissioner, do you have any final remarks as we close out?
Only thank you to everyone for taking the time today. This was a wonderful attendance and a really wonderful start to a dialogue. And I'll close as well by saying thank you to Teresa once again. We too look forward to continue dialogue with the hospitals and many others. And please reach out to the office, Cory and myself, and we're happy to continue dialogue with anyone and answer technical questions working with our partners at NASHP. So just thank you all, and we wish you all a good rest of your day. And thanks so much for everyone's time on this important issue. Take care.